Welcome back once again to another episode of Made for Health. Myself and Dr. Jenski, my partner in crime, as always. The typical things, this information is for educational purposes only. You cannot diagnose or treat anything. Of course, discuss anything you learn here with your primary care provider. On that note, today we're going to talk about an interesting topic that has been around for thousands upon thousands of years in ancient historical books, and yet is still bewildering and bemusing to the most scientific of all people. I use the word mystery illnesses to encompass a bunch of things. The paradigm typically is your mold patients, water damage building, mast cell activation syndrome, your autoimmune patients, your MCAS, mast cell activation syndrome patients. There are 4 or 5 major ones of these, but the concept of mystery illnesses actually is old. For example, in the Old Testament, there are actually parts of that where in the ancient Israeli Jewish law where you actually have to cut out part of your building if there's mold in it. This is 1500 BC. If you have a mold, you cut it out, it comes back, you literally destroy the building. Infections, tuberculosis, syphilis, the great imitators. Certain diseases people would get from exposure, like lead in ancient Rome, for example. They actually stored wine in lead containers. And we think some of the insanity of ancient Rome may actually have been people going crazy because of lead exposure. Yeah. Different miners in Peru in the silver mines, people would get so much mercury in their systems. Then when they died, there'd actually be pools of mercury where their bodies would decay. So environmental toxin exposure, work-related exposures, infections. So all of a sudden, this new idea of mystery illnesses actually is I wrote down it's an old concept with new science. So these are the topics we're going to talk about over the next couple episodes. Those are my introductory remarks. I don't know if you have any other introductory remarks about.
No, that was great.
Oh, thanks. But the idea is and this is something we deal with on a daily basis.
Yeah.
So maybe the question to you is, Dr. Jenski, have you ever seen a mystery illness before? These kind of things. And why do people come to us with these things? Other providers, other physicians, other specialists are overlooking, under-recognizing. Why do you think they work their way to us?
Yeah, I think it's because we don't really see them as mysteries. To me, the term mystery illness is a little bit of a misnomer. It's common in our practice. It's mysterious elsewhere. And it's because there's not a definitive way to diagnose it, or there is a constellation of symptoms that overlaps with another constellation. And so when there's not clear black and white clarity, it's often befuddling to conventional medicine. They need that black, white, gray they don't do well with. You need a disease label so we can give you a prescriptive Band-Aid. If you have to do a therapeutic or diagnostic trial of intervention, if you have to look at a constellation of symptoms, combine with some screening tools, combine with this lab and maybe this lab, and then have a conversation with the patient, that's not really where conventional medicine shines, but it is kind of where we do. So I think as these individuals have kind of essentially weaned themselves out of conventional medicine, they found their way to us because they haven't met the specialist that's able to diagnose or determine what the cause of their problem is. And then they land on our doorstep, and it's you hear a couple of buzzwords in an interview, and it's oh yeah, you have mast cell activation. At least that's what I clinically think is going on. Let me get some labs. And even then, the labs, and we'll talk about this, they might not give you any insight, but you then do a trial of intervention, and that gives you the insight. There has to be a degree of intellectual medical curiosity. There has to be clinical acumen. There has to be the willingness to do something that is safe, not harmful, something you'd be willing to do yourself, but not necessarily the standard of care, not necessarily FDA approved. The whole goal is do something. Don't say, I don't know. Don't say, I have no options for you. Just try to figure it out. So I think that's really why they wind up on our doorstep, is because they're just kind of gaslit until they eventually find us.
I like everything you said, but also to take that a little deeper as well, is that we are the specialty between the specialties.
Yeah.
And so that's when people have been asking me recently, what do you do? That's kind of my new thing I'm saying, because it's the reality. It's you see your cardiologist for your heart, you see your GI doctor for your gut, you see your rheumatologist for your autoimmune issue. But who talks about the gut issue being related to the rheumatoid and the heart stuff? Who talks about the autoimmune disease in your arteries called cardiovascular disease, right? And so if someone has I don't want to say a one-trick pony, but I just had a massive heart attack. I just had my appendix removed.
It's specialized or
yeah,
subspecialized.
100%,
I mean,
100%.
it goes even deeper because now they're subspecialized. And
Yeah.
so I've not heard you say it. I like it. So we're the interstitium, right? Like we're the glue. We are the connective tissue that holds the body together and holds these different organ systems that have been compartmentalized together.
And the connective tissue, it's the unappreciated, unrecognized,
Unsung hero.
that gets no the Rodney
Yes.
Dangerfield. I get no respect here. Yet the thing that holds everything else
Yeah,
together.
right.
That's the first thing I wanted to say bouncing off what you said. The second thing is that there's this thing called vomit syndrome that I learned about at a trauma course, probably in 2003, 2004. It was actually a surgery trauma course in Virginia Beach. And vomit syndrome is we're victims of modern imaging techniques. And the concept is we become so specialized, and this was over 20 years ago. Keep that in mind.
Yeah.
We become so enamored with technology that clinicians are no longer clinicians.
Yeah.
We're no longer diagnosticians. We're technologists. I think you have this issue. Let me get a CT. I think you have that issue. Let me get an autoimmune panel. And we've lost the art of medicine.
Mm-hmm.
We've lost the art of diagnosis. And literally these diseases, the interstitium, the space between the specialties, specializes in that.
Requires that.
Yeah, it requires that. And that's something it's a lost art. We talked about William Osler. We learned about him in medical school. He was the guy. Back in the day when they didn't have therapies, people got really good at diagnosing things.
Mm-hmm.
There weren't a whole lot of treatments, but they literally had to listen to a patient. They could feel their pulse, listen to their heart, and tell them which valves are off, right?
Mm-hmm.
And no one does that anymore. But they got really good at making diagnoses, and we've almost done the exact opposite. We're really good at ordering testing now,
Mm-hmm.
but we've lost that clinical acumen. And literally these things sit in that space.
Yeah, that's what you need for this. And not that there's not testing for it, but the testing isn't always helpful. And if it is, great. But if it's not, then what? It doesn't mean they don't have it. You have to use your clinical acumen. You have to use the art of medicine. And that goes along with treatment plans too. I mean, you know this. Every single patient you see is different. That's the whole point of what we do. But plan A may not be the plan that they're responsive to or tolerant of. A lot of these patients also have chemical sensitivities and react to stuff. And so you have to play that card too, where it's not just, okay, your presentation is mysterious. The ability to work this up is a little bit muddied. And the first plan I put in place, you can't tolerate. Then what? If you don't have the ability to pivot, if you don't have the ability to be flexible and let's say artistic in your practice of medicine, you're not going to get that patient better.
Yeah. And what other concept? I kind of lost my train of thought after that. Okay, yes, the multi-system, multi-symptom illness,
Complex biological illness. Yeah.
and roughly they're 80% similar. Chronic Lyme, chronic tick-borne illnesses, reactivation of Epstein-Barr, mold-related illness, post-concussive syndrome, chronic inflammatory response syndrome. Now people are more aware of these because of long COVID, but the long COVID-like symptomatology is something in this world. We've been working chronic fatigue and fibro for decades. And so to your point, you do need to have that toolkit of your clinical expertise. And we both have been doing this for 20 plus years, as well as the ability to order fancy testing, but also requires longevity in a relationship with the patient. Like, I talk to my wife, we were married for about 15 years before I realized one of her big triggers was grad school. We've had this conversation before. We all literally all of us went to the same anatomy class. She had a massive formaldehyde exposure first year in grad school that caused horrible anxiety, almost dropped out of school multiple times, ended up starting getting better as the year went on. She thought she was just coping better with school. It was just, she was getting a distance from lab. And funny talking with you about that, you had this weird kind of feeling about anatomy lab where you just like,
I stopped going. I just learned from the textbooks. And then I would show up during practical exams. I would lean heavily on my classmates. They were aware of it. I wasn't aware of what was going on, but I let them know how I feel. They probably thought that I was a bonehead, but the reality was that I was getting sick. And so I would show up, I would push through, I would feel unwell. Thankfully, I passed and didn't have to repeat the course, but it was the formaldehyde for sure.
Yeah, and so on that note, this is common, it's everywhere. And let's actually start with one of the most ancient of the mystery illnesses, chronic infections.
Yeah.
Now, I like to talk about Lyme because, when was the first, I assume, maybe we have similar knowledge bases. But the first actual diagnose, like when did we first, in the history, when was the first individual with Lyme ever?
I have no idea.
Oh, okay. That's
like
what
ancient Egypt? I don't
it
know
was.
when.
Okay. I'm sorry.
I'm going to guess. I'm going to just throw a Hail Mary.
Well, there was, 5,000 BC. We actually found a frozen cave guy in Switzerland area who was running away from some people. He had a head injury, had some additional mushrooms on him. So, they do these little finds and like try to figure out the culture.
Yeah.
Did blood DNA testing on him, and he had Borrelia in his blood. So we don't know if he had Lyme disease per se, but we know the Lyme spirochete has been around for 7,000 years.
Yeah.
But yet it's causing havoc. Same thing for syphilis, same thing for tuberculosis. Epstein-Barr has been around forever. So let's talk a little bit about the one that everybody's talking about now, I feel like, which is Lyme.
Yeah.
How common is it? Do we see it? Give us a little brief overview of Lyme.
Yeah, so more common than I think people want to admit, and often overlooked unless it presents very classically. I mean, we live in a Lyme endemic state, so we see it more often, but it's spreading. It's not confined to Connecticut. It is up and down the East Coast, and it's moving out west, Midwest. I mean, it's just kind of everywhere. And as the climate has changed, this has become more and more of a problem. We're seeing new species. We're seeing more cases. We're seeing atypical cases. The incidence of the classic, bullseye rash, and yes, I know I got bitten by a tick, and it was a deer tick, and it was this time of year, and it was on my body for this period of time. Like, that is incredibly rare. Having worked in the emergency department, but also in urgent care, like, it was very rare that someone came in with a presentation like that. And so in this situation, I take a history on a patient, and like, of course they've been bitten by a tick. Of course they pull ticks off of themselves or their pets or whatever the case may be. So I think it's incredibly common, but we also see a lot of the co-infections too. And I'm sure we'll touch on this, but Bartonella, Babesia, and some of these others that we're seeing. So I think Lyme is very common. I see it often. The problem is that its presentation isn't always obvious, and the timing is really, really hard to pin down. So you have to have a high degree of suspicion if someone presents with a history of a tick bite, is having fatigue, muscle aches, joint pain, obviously a rash, maybe a low-grade intermittent fever, headaches. Those are kind of the classic presentations. That's for early. Then if it gets disseminated or you start to get secondary or tertiary Lyme, they start to have cardiac or neurologic manifestations, it's a problem. So you got to pick up on it sooner than later. It tends to hide. Lab testing is not easy. CDC has strict criteria. I get equivocal results all the time. You just have to make an educated decision with that patient, what's best for them in that clinical presentation, to determine what the next best steps are. Are you going to use antibiotics, and for how long? Are you going to use botanicals, and for how long? Do you need biofilm disruptors? Do you need to test for co-infections? Do you need to expand out to specialty testing? I mean, it just gets deep. And there are these certified providers that are, Lyme literate MDs or ILAD certified that are out there fighting the good fight, but even they are not convinced exactly what it should look like when someone presents. But they're more amenable to keeping their eyes open for it versus just, oh, you didn't meet CDC criteria, therefore you can't have Lyme. Like, to me, that's clearly not appropriate.
And I want you to clarify that statement, because that's a good point you said. You were in the ER for 10, 15 years, in urgent care for 3 to
4 years.
4 years,
Yeah.
okay. So the question for you, at the front lines, how often do you see Lyme? And the answer is?
You see it all the time.
In the ER.
In there, I wouldn't see it at all in the ER.
Okay.
Yeah. In urgent care, people come in all the time saying, I got bit by a tick. But then you don't know. And then how do you get lab testing? How do you follow up on that? How do you do that appropriately?
Yeah. It was interesting because when I did my training at VCU and MCV, we did the same place. And I went in the military for 4 years, traveled around the world, went to Germany, et cetera. The first case of Lyme I saw was a patient when I came back here, did the test on them, and was positive. I wasn't quite sure what to do with it because I'd never seen it before.
Yeah.
So I called the local infectious disease doctor and was told they don't take consults for it, and it's not in Central Virginia.
Yeah.
And so that was 2007, where I had to I have to figure this out on my own.
Yeah.
And so, according to the CDC, there are more cases of acute Lyme by their criteria, which who knows what the numbers really are, right?
Yeah.
More cases than there are new diagnoses of breast cancer every year. So it's really, really common.
Yeah.
And, I have a couple of patients that are veterinarians, and one of them I was talking with, and they're like, oh yeah, 25% of all dogs that come into our clinic test positive for Lyme. We don't treat them all because they don't have symptoms, But I started thinking, dogs have owners.
Yeah.
And most of the dogs that they're taking to the vet are usually indoor dogs.
Yeah.
They go outside, pick up some ticks, probably drop them off in the house. That's where my son's got.
Yeah.
He got Lyme about 2 years ago, and fortunately caught it early. I knew what to look for. Got him on antibiotics. 2 weeks later, he was fine. But it was from the dog hopping in his bed.
Yeah.
So my question is, how many people with pets have the Borrelia?
Yeah, for sure. Let me clarify the ER comment even further. You never test for Lyme in the ER. It's not an ER test. When someone comes in, let's say with body aches or a headache, like you're ruling out sepsis or you're working up a migraine, no one's thinking Lyme.
Yeah.
They might, if they're sick enough, get admitted for some reason, and then the hospitalist or infectious disease gets tapped, and then they might work them up. In urgent care, people would show up and, hey, I got a tick bite and I have a rash. I want to make sure I don't have Lyme. And then you have to kind of figure it out. But even then, it was just like, what do you do? That person may not have a primary care. That's why they're in the urgent care. What's the timing? If I get blood now, is it too early? Is it going to be a false negative? And so there's just so many layers to it. You have to have that clinical suspicion, but it is incredibly common.
And on a side note, one of my friends, a colleague, Cynthia Thurlow, I've talked about her before. She was for a long time a nurse practitioner at Johns Hopkins in the cardiology. She did ER and cardiology, and they have patients come with heart blocks.
Yeah.
And they were routinely checking them for Lyme and finding them with Lyme disease.
Yeah, that's awesome that they were doing that.
But this is like they already have a heart block.
Yeah.
This is at a specialty center in Johns Hopkins.
Yeah.
Does that happen here in Richmond, which we're like 2.5 hours south from there? No. And so the point being is this is ridiculously common.
Mm-hmm.
Some people recognize it. Most don't know. And the other caveat I want to add to that is I've at this stage been working with patients for years, and I've been patients. I've checked for Lyme every year because it's here. And over the last couple of years, there's been patients I've been working with who were negative, 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 negative. And all of a sudden, one day in the middle of wintertime,
Positive.
they flip positive.
Yeah.
You have to ask yourself, the ground's frozen,
Yeah.
there's frost on the windows, and your Lyme flipped positive.
Yeah.
It's been there.
Yeah, it's not new.
And so now some of the question is, how many people have it, like Epstein-Barr, like herpes, like chickenpox?
It's reactivated.
And it gets reactivated.
Yeah.
And then all of a sudden, like, is the goal cure? Is the goal dormancy?
Yeah.
So these are all things I think that play to the mysteryness of Lyme. And this applies to every infection. It's not just Lyme, it's Babesia Bartonella, like you said,
Ehrlichiosis. Yeah.
but also viruses, reactivation of Epstein-Barr,
Mm-hmm.
herpes. I remember I've been in the hospital and seen patients coming in with altered mental status from herpes encephalitis.
Mm-hmm.
There's an association with Epstein-Barr and a whole host of autoimmune diseases, including Hashimoto's and multiple sclerosis.
Mm-hmm.
So all of a sudden,
And cancer, Burkitt's lymphoma.
100%, yeah. So the point is that infections are a mystery kind of thing.
Especially the ones that hide. Like Lyme's pleomorphic, that changes shape, right? Lyme can go from spirochete to cyst and back. It hides in all kinds of tissue. It is highly mobile. It's not a stupid bug. That's why it's been around for 7,000 years. Like
Plus, yeah.
Yeah, plus. Like it knows what it needs to do to survive. It's gritty like that. And it's hard because, like you said, you get negative, 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 then positive. And the question is it new or has it been there? And then what are you going to do about it? And it's kind of, that bit of information reminds me a little bit of like when we talk about that incendiary moment in a patient's story where like I felt fine until like some event happened that unleash other things that were already there to begin with. Like these dormant infections or this toxic burden that overflows the well, so to speak. Like this is incredibly common.
Yeah. And to your point, it's not the acute, I got a tick bite, I got mono with the big swollen tonsils,
Yeah.
I've got strep
That's
throat.
easy. All that stuff's easy.
Yeah, it's usually something insidious
Mm-hmm.
that then triggers something. And it could be one of my patients graduated from UVA, was going to medical school, hiking the Appalachian Trail, got a tick bite, got Lyme, got Hashimoto's. Come to find out, the setup for all that stuff was mold.
Yeah.
Set him up.
Yeah.
The tick bite triggered it. He went to the doctor for thyroid, worked his way around. But it's like, again, multi-system, multi-symptom, and that's our specialty.
That's really common. I mean, that Andrew Heyman talks about that all the time. Like when he opened up his practice in Northern Virginia, and he had this like subset of the sickest of the sick, and he was like, I don't know what's wrong with these patients. Wait, I live in Virginia now. He came from, I think, Michigan. I live in Virginia now. Let me start checking Lyme. And all his patients tested positive for Lyme or were close enough where he's like, maybe I should treat this. And he did. And then a subset of those patients got better, but then a subset of the sickest of the sick didn't. And they were all mold patients. And then he went back and realized that all of them were mold patients. And it was the mold that had triggered the Lyme that had been dormant all along. Some had new infections, but it was like, you just see it like dominoes. And if you can kind of take a step back and look at it, you can kind of see this lineage of events happening over time. That's the whole point of taking a good history. And then you start to kind of peel the onion, so to speak, and get to these layers, and patients can get better.
Yeah. So actually, next episode, we'll talk about SIRS.
SIRS, yeah.
Because that's the big mold one.
Yeah.
So again, back to multi-system, multi-symptom. So let's go back. We'll take a system. So let's talk about the nervous system. What are symptoms we see? These apply to all of these. And this is where we're not going to go into the nuances of the clinical evaluation, but if you have any of these symptoms, think any one of these 5 that we'll be talking about over the next several episodes. So neurological system, anxiety, brain fog, panic attacks. You can see sleep disturbances. You can see dysregulation of regulation. So temperature dysregulation issues, blood pressure, pulse dysregulation issues, a whole host of things in the nervous system that can be associated with this and others.
I would even add fatigue to nervous system. Yeah.
Sorry, that's the big one. Fatigue is like the big one people usually.
But people don't really equate fatigue to nervous system, right? To your brain. It's like fatigue. Oh, it's my thyroid, or I'm stressed, or I'm not sleeping, or my sex hormones are off. It's a neurologic symptom for me.
100%. Yeah. So why don't you take a system and give us some symptoms?
So cardiovascular. So you see hypertension or hypotension, so high or low blood pressure, dysautonomia, all the way to POTS, postural orthostatic tachycardic syndrome. So high heart rate, low heart rate, heart blocks, dysrhythmia. So, someone whose heart is too slow, or skipping beats, or having extra beats, or popping into a rhythm that isn't your normal sinus rhythm. Vasomotor symptoms, flushing of the skin. Those are, to me, dizziness, especially if it's related to positional changes in hypotension. I think that would be the cardiovascular stuff.
And when you think, when we did our training through A4M, they talk about cardiopulmonary neurovascular as like one of the systems you look at. When we think heart, it's also the nervous stuff associated with the heart, and also the vascular stuff. So all of a sudden, Raynaud's, cold hands, cold feet, blanching of your skin, looking at someone's legs, they have that mottled appearance. So many different symptoms that say there's a dysregulation in blood flow, which means circulation volume, and nervous system as well. Yeah. Because those systems go together.
Yeah, they go hand in hand. Every blood vessel travels in a neurovascular bundle, right? Artery, vein, nerve, wrapped in a sheath.
Yeah. With immune cells there as well, which is where mast cell comes into play. We'll talk about that later.
Yeah.
Gut symptoms. What kind of gut symptoms do people get with all of these, not just Lyme?
I mean, diarrhea, constipation, like all of them. Diarrhea, constipation, bloating, gas, heartburn, pain, you name it. I mean, like...
Organ pain. Sometimes people get kidney pain, liver pain. They'll say it's my kidney, it's my liver, gallbladder. You can actually have...
Colic,
My mother-in-law actually lost her gallbladder in Northern Virginia after my sister-in-law's getting married, lots of stress, went to the hospital. She had a gallbladder, removed it. She got this crazy rash. They thought she was reacting to the antibiotics. Come to find out, she had auriclia.
No way.
And so she lost her gallbladder, got in the hospital, got the rash. Then they thought it was the antibiotic, and it actually was, now we know, is auriclia.
Yeah.
And so sometimes you have these weird presentations of a gallbladder or an appendix. Yeah. And it's literally the immune system inflamed.
Yeah. And
that was one of those interesting kind of like, and the physician who saw her in the hospital actually ended up being a Lyme specialist up in Northern Virginia. So she was fortunate.
That is fortunate. Organ inflammation, that's a good point. So hepatomegaly, splenomegaly, big liver, big spleen, it's classic for mono associated with Epstein-Barr. So you can see organs get enlarged. You can see the GI tract kind of suffer. And then secondarily, if the GI tract is getting a hit, then you get mast cells unleashed, and now you have all the mast cell stuff that follows suit, and it just becomes, again, like the domino phenomenon.
And I love that point you mentioned about the lymph nodes, because how often will we see someone who had a CAT scan or a CT, and they said swollen lymph nodes in the neck and the chest, and they go to the pulmonologist to rule out cancer or whatever doctor, and they come to us. Everybody's done their testing, and my lymph nodes are still swollen. I still have pain in my groin. My spleen, I can still it's a little big, like you said, and it's like, okay.
The immune system's active for a reason.
For a reason.
That, maybe badness has been ruled out in the way of cancer. Great, but what's the cause? Literally, I have a patient that just saw Jody for this. She's got some random lymph nodes that are swelling, And Jody ran a viral panel on her very astutely, and her EBV is off the chart. And that is her only symptomatology. And so we're treating it. And I can't wait to see her lymph nodes go away. Like that's the whole point. Like, this is what needs to be on people's radar if they're trying to practice whole person medicine. You have to think about these things. They're not mysterious. They're well documented. They've been around forever.
Gotcha. So we've talked about Lyme on the podcast a lot in the back. So the point of this series is just mystery illnesses. If people have additional questions, want to learn more about this, we have tons of blogs on it. We've done lots of interviews on it in the past as well. But again, the idea is mystery illnesses, what's being missed. And I think the next one we'll talk about in the next episode is chronic inflammatory response disorder, which includes, but it's not limited to, mold.
Mold, yeah.
Take care. Be well. We'll talk to you soon.
See you soon.